Hello, this is Dr. Amy Beltwell. I'm the co-principal investigator of the Agency for Healthcare Research and Quality's Reducing Medicaid Readmissions Project. I'm pleased to welcome you to the fourth webinar in our six-part webinar series to support the dissemination of the Hospital Guide to Reducing Medicaid Readmissions, Designing and Delivering Whole Person Transitional Care. This is the fourth webinar that focuses on the I part of the AHRQ framework, which stands for Implement Whole Person Transitional Care for All Patients. The agenda for this webinar is to describe the guidance and proposed changes to the CMS discharge planning conditions of participation, and to identify the ways in which we believe this guidance and the proposed changes promote whole person transitional care and are particularly relevant to improving transitional care for Medicaid patients. Finally, we will share tools from this guide to support improving whole person transitional care for all patients. The objectives of this webinar are for users of the guide to understand that hospitals should improve transitional care processes in ways that apply to all patients regardless of readmission risk. To understand that all hospitalized patients should be assessed for readmission risks and transitional care needs, and to identify ways to implement improved care processes for all patients. To remind you where we are in the AHRQ framework, this is the Hospital Guide to Reducing Medicaid Readmissions and the table of contents, and today we're talking about the chapter focused on Implement Whole Person Transitional Care for All. We will cover tools 8, 9, and 10, which correspond to this section of the guide. And as a reminder, this is the AHRQ framework, which supports your readmission reduction team in developing a data-informed, strategically designed portfolio of strategies based on a multifaceted analysis and design set of work, as well as delivering improvements in the following three complementary domains of improving standard processes for all patients, collaborating across the continuum, and delivering enhanced services for high-risk patients. So we encourage readmission reduction teams to understand the evolving guidance and requirements that are coming from CMS, as well as from relevant state agencies and other payers and regulatory authorities that you may be subject to. Use these evolving guidance documents or proposed rules as your blueprint to improve standard care. Far from being a minimum floor, especially the discharge planning surveyor guidance, as well as the proposed changes to the CMS conditions of participation for discharge planning, represent a meaningful improvement in expectations for what all patients, each one of us, would benefit from if we were hospitalized these days. So what we see in the concept of improving standard care processes for all patients is not only should all patients be assessed for high risk of readmission features, but all patients should be assessed for clinical, behavioral, and social needs that need to be addressed as part of their hospital plan of care and part of their post-hospital transitional plan of care. We need to embrace the practices that have been well described around communicating with patients simply and effectively. You will all recognize that this means using health literacy and literacy appropriate written materials, using interpreters as necessary, and using the teach-back technique in order to convey the essential self-care next step tasks for patients and their caregivers. We need to link patients to follow-up and post-hospital services, not just refer patients to figure it out for themselves. We need to provide real-time information to the receiving providers. Sometimes this is electronic. Sometimes this is a warm handoff. Sometimes it's a combination of both. but that real-time information for receiving providers is part of what improved standard care is for all patients, not just high-risk patients. And finally, all patients need to have timely post-discharge contact. Whatever timely is based on their readmission risks and what they need followed up on, but everybody needs to have ensured post-discharge contact is in place. Not only do these basic elements of what, quote, discharge planning, now called transitional care, what improved transitional care looks like, but hospitals need to have a process in place, a written, standard, known, knowable, measurable process. What is the transitional care process for all patients in our hospital? Hospitals should track, trend, and review readmissions to inform continuous quality improvement, and to use those insights to continually improve the standard operating procedures at the hospital to better meet the needs of all patients in addition to high-risk patients. So many of these concepts are directly taken from recent CMS guidance documents and their November 2015 proposed changes to the discharge planning conditions of participation. So the documents are cited and referenced in the guide for your information, and I do personally recommend that at least someone on your readmission reduction team read both the May 2013 surveyor guidance, to which updated the recommendations for what surveyors should look for in the discharge planning process, as well as the November 2015 proposed changes to the discharge planning conditions of participation. For those of you at your hospital who are not only involved in compliance, but in quality improvement and designing strategies, the likes of which we're discussing in this webinar series, these are important documents to read, not only for regulatory compliance, but also to inform and bring greater specificity to your quality improvement work at the front lines. So I won't read out all of the bolded phrases, but I will highlight a few. So the CMS in its guidance or proposed changes to discharge planning rules require us to have a written discharge process to analyze and track readmissions and review readmissions for opportunities for improvement. Every patient in a proposed rule is proposed to need a transition of care plan. The plan must be realistic. It must involve the input of family, friends, or other relevant support persons of the patient's choosing. Interestingly and importantly, it must address behavioral health follow-up as part of the discharge plan. The discharge plan and the discharge process must provide customized education, which is something that many hospitals have accessed libraries of pre-prepared information, and I think it's interesting to reflect on this requirement to provide customized information, verbalized instructions, using the teach-back technique. We'll all notice that 5 to 7 years ago, teach-back was a novel, emerging best practice. Now here you can see that these expectations are being baked into what is expected for all patients all the time. I find this next set of guidance principles extremely informative and forward-thinking. This is from the May 2013 Surveyor Guidance, that hospitals must know the capabilities of their community-based providers, including Medicaid home and community-based services, know the options for Medicaid long-term services and supports, or have a contact at Medicaid who can help navigate. And I like that because it reflects the fact that these programs and these services and eligibility and agencies change all the time, and so having a point person to help a hospital-based team navigate the Medicaid home and community-based and long-term services and supports environment is very wise. We must, a proposed change is to provide patients with data to inform their choice of who delivers post-acute care to them. And we must transmit discharge summaries within 48 hours of discharge, which might be a significant workflow change for some hospital providers. And there's a proposal that hospitals follow up in one way, shape, or form with patients at high risk of readmission after they leave the hospital. So again, this is just an excerpt from these two primary documents that we're sourcing, that we're referencing, but it, to me, paints a picture of what improved standard care for all patients looks like and is a fairly robust blueprint for moving forward. In addition to the CMS, to the changes that are propagated by CMS regulation or guidance, many of you operate in states with rapidly evolving Medicaid rules. And one example is from New York, where the New York Department of Health Medicaid agency is undergoing an $8 billion delivery system reform incentive program for Medicaid, the unified aim of which is to reduce Medicaid hospital use by 25% over 5 years. As part of what's called the DSRUP work in New York Medicaid, there is a transition of care process that hospitals are expected to engage in. And New York Medicaid has identified the key components of what a transition of care process needs to look like for each hospital that's doing this work. And they have identified that, like CMS, hospitals need to have a transition of care process written down in place. Hospitals must partner with Medicaid managed care organizations and community and social service agencies. That hospitals must notify the patient and receiving partners in the community of discharge as early as possible, no later than 24 hours prior to discharge. Allow the transitional care providers from the community or from different agencies to actually come in to physically visit the patient prior to discharge. That hospitals need to ensure timely communication with receiving providers and to establish and track patients during a 30-day transition of care period. So again, these are excerpted elements of what the New York DSRUP transition of care model looks like. And so to round out the two sets of requirements, in New York, with an 11-hospital regional collaborative, we sat down and we looked at the CMS requirements, we looked at the New York Medicaid requirements, and we tried to rationalize and understand all of these requirements in a way that helps these different agencies' requirements seem harmonized and aligned. And we needed to identify what was unique on one side of the column and what was unified across both sides. And so again, this is just one example, but you might, depending on what state you're in and depending on what your Medicaid agency has in place, you might want to do this work of comparing and contrasting the federal requirements with the state requirements and identifying those areas of alignment so that you can harmonize your work instead of feeling like you're exposed to so much regulation that might seem disparate and disconnected. So once we looked at what the requirements were, and this is again harkening back to this 11-hospital group in New York that looked at the CMS requirements and the New York Medicaid requirements, they then surveyed across these 11 hospitals, and they found that, you know, truth be told, as expected, there's variation across all the hospitals in how these hospitals target patients for readmission reduction services. Most hospitals were using some way of identifying patients at high risk of readmission, but there was variation across all the different hospitals. Most hospitals were working on improving patient education and medication reconciliation in one way, shape, or form. But here's then where some of the drop-off occurred. They found that very few hospitals were working on any sort of efforts to ensure follow-up. Few hospitals had a process in place to coordinate actively with community providers. Few hospitals had efforts that required shared accountability for shared aims like reducing readmissions. And few hospitals, if truth be told, were tracking services delivered or the outcomes of those efforts after discharge. And so in our field work in this project, we have encouraged hospitals to look at these various documents, the surveyor guidance, the proposed changes to the discharge planning, conditions of participation. And on one level, the folks that are charged with ensuring compliance and mitigating risk at your hospital, they might say, oh yes, of course, we are in compliance. But something that we encourage you to do as you reflect on the slide here that you see here is use these elements of transitional care best practices to ask yourself from a quality improvement and system redesign perspective, to what extent are we executing reliably on any of these elements, and to what extent are we, do we have opportunity for improvement, or are we really not consistently implementing some of these elements? And that's, of course, what we saw here across these 11 hospitals. They could have been any 11 hospitals in America. I think this is quite representative. So here you can see the following tool that we've developed, which we call the CMS COP requirements tool. And what we're encouraging this tool to be useful for is really awareness raising. It's awareness raising for you as an executive sponsor of readmission reduction, for you, the director of care management or integrated care at your hospital, for you, the case managers, discharge planners, social workers, and hospitalists, and IT staff in your hospital charged with contributing to efforts to reduce readmissions. This, when we put the whole picture together and put these various elements of improving transitional care together on one page, we're hoping that this will help create a roadmap for which you and your readmission reduction team can not just reflexively say, oh yes, we would be in compliance with these requirements, but rather say, to what extent are we doing this, and are we doing it as well as we possibly can? A companion tool to that COP requirement tool is a discharge checklist, which again is excerpted from the CMS guidance. So there are many discharge tools out there, discharge checklist tools out there, and they're all of fine quality. This we offer for you as an excerpt from the very same documents that we are citing to you, so that you can have some sense of what's in these documents and what the discharge elements are that are required coming out of these documents. So it's really meant to build on any checklist you already use, or if you don't have a checklist, you could look at this as meeting the requirements in these CMS documents. So once we think about improving transitional care in a standard way for all patients, we then move into the opportunity to screen all patients for transitional care needs and address the needs that we find. And so this is quite different from a concept that says we're going to screen patients to see if they're high risk of readmission, and then we're going to do something different for patients who are high risk of readmission. We agree with that later statement. However, we also encourage you to screen all patients for readmission risks and transitional care needs, and that a good and complete and thorough hospital-based process says that a person's transitional care needs are met regardless of whether or not they're, quote, high risk of readmission. And so what do we mean by that? We mean that any patient who has functional limitation, access problems to ambulatory care, limited or no access to behavioral health care, financial, food, housing, transportation, insecurities, that these are all elements that should be actively screened for and addressed as part of a reliable, high-quality transitional care process based at the hospital. A subset of patients will be identified by your high-risk criteria, whatever those may be. But that in the process of assessing all of your patients who are admitted to the hospital, look for these whole-person transitional care needs, and where you find a need, incorporate a strategy to address that need in the transitional care plan for every patient. So here are a few implementation tips from our work in the field on how to improve standard hospital-based care for all. Number one is to use a whole-person transitional care planning tool to review the assessments that your staff already conduct. So you can take that sheet that I just showed you, and you can sit down and you can look at the nursing initial assessment, the case manager's initial assessment, the work that a case manager does in the course of creating a discharge plan for any given patient. You might look at what the social worker would be involved to screen for and address. You might look for what a chaplain would be involved to screen for and address, and so on, PT, OT, nutritional therapy, etc. It's very likely that in the course of looking at what all of your interdisciplinary staff query for as part of their day-to-day patient care work, you are highly likely to find that most of these questions are asked by some provider at some point during the hospitalization. The challenge is that the information then gets contained in each individual provider's note, and you then can ask yourself, do we have a way to bring all of this, quote, whole person needs assessment information into one place so that we can see what the social worker found, what the physical therapist found, what the admitting nurse found, what the admitting hospitalist found, et cetera, with regard to transitional needs. By no means is this an easy task, but this is a task that is a work in progress, something that's worth evolving toward to try to get all of these interdisciplinary assessments into one place. So we recognize that in an electronic environment, a paper tool like this whole person assessment tool may or may not have a place in your workflow, but hopefully either you can test it and see if it's helpful. You can still, attach it to the front page of a chart or make sure that it's part of some discharge planning paperwork, or you can look at the elements here on the whole person assessment tool, and you can use it to think about, are we collecting this information, and if we are already collecting it, how can we bring it all together for a complete whole person view of this person and their needs once they leave the hospital. The third point here is based on your inventory of what's already being asked and what is on this whole person care planning tool, you may see opportunities to either use the tool or to update your existing nursing, case management, discharge planning, or social work assessments to more consistently address elements that could be considered whole person needs and Medicaid relevant risks. So you might take what's on this whole person assessment tool and you might incorporate 3 or 4 or 5 queries into your existing nursing, case management, discharge planning, social work assessment tools that might be electronic, you incorporate into your electronic workflow. Finally, we've seen teams with very good effect leverage the new electronic workflow environment that can prompt questions to promote efficiency, so that the use of checkboxes, check, 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 clicks, review and confirm prior events, etc., can promote a reliable, consistent whole person, a capture of whole person transitional care needs, and the workflow prompt system promotes consistency in asking those questions and capturing that information. Among the most important messages we can convey from our field work, as well as from my personal clinical experience, is we don't want to get lost in assessing domain by domain by domain for individual elements that create a readmission risk or need for a patient. That the most important thing is to remember to listen to why our patients came in the first place. And as you've heard in prior webinars, we're always listening for the story behind the story, not the chief complaint, not the primary diagnosis, but what brought the patient to the hospital as opposed to seeking care in any other way, shape, or form. So here's an example from one of my patients that I admitted last year, who we rounded on mid-morning one day when we first met him. And we found that he was a 53-year-old gentleman with HIV who presented to the hospital with a chief complaint captured by the nursing triage as, quote, unable to walk. He was promptly admitted to the medicine service. The next morning, once he reviewed his labs and his vitals, we came and we met him, and he appeared to be quite clinically stable. I asked the patient to tell me again why he came to the hospital, because everything looked pretty much in order. He looked pretty good. The patient very clearly and quite articulately explained exactly why he ended up in the hospital. He had run out of his gout prevention medication, and his inability to bear weight on his leg was simply the result of a gout flare. The patient came to the hospital setting looking for a steroid injection, which he had had in the past to good effect. But because he presented with this combined label of HIV and, quote, unable to walk, he had been promptly admitted for an issue that could have otherwise been a treat and release issue and managed as an outpatient. So again, this doesn't happen all the time, but I recommend that the more you look, the more you'll find incidences where a patient with a, quote, complex set of clinical circumstances is admitted to the hospital for reasons that really could have been addressed in other ways. And what we need to do as a team and as providers focused on avoiding readmissions is to really listen for this and to not over-medicalize the presentations when they come to us. So, of course, the whole person needs for that gentleman were to really problem solve around why did he run out of his gout medications? Was this a simple forgetfulness error? Could he not get medication reauthorized over the phone? And then what is his strategy for seeking care in the future when he does have a gout flare? Can we please get him to a family practice doctor or to a rheumatologist who's comfortable providing outpatient intra-articular injections instead of having him rely on the emergency department, which in this case was did not address the presenting issue, but rather assumed that he had a more complicated medical issue going on. So you can see that the transitional care planning and the whole person needs are a very different set of discussions and strategies for a gout flare as opposed to a patient with complex HIV needs. So again, an implementation tip here on identifying high-risk patients in order to focus our intensive transitional care planning services. We've seen increasing numbers of hospitals use flags to identify patients with high-risk features upon admission, based on your knowledge of your data and your root cause analyses. So what does this mean? This means that you can create a program in your registration software or your electronic medical record or your ED tracker board to identify a patient at high risk of readmission when they first register at the hospital. So that flag might contain a trigger for a patient with a prior history of multiple hospitalizations. It might be a patient who has a personal history of a behavioral health comorbidity. It might be a Medicaid patient because you know that your Medicaid patients are at high risk of readmission. It could be a condition of high risk, such as heart failure, sickle cell, etc. So there are many different ways to flag patients that you know belong in a population that has a higher than average risk of readmission. Not only is it very helpful to flag high-risk patients on admission, but the second part of that flag is that you can use that flag to send alerts to staff to promote timely action. So what we see is that a high-risk alert can be pushed to case managers, hospitalists, the readmission reduction team, in order to raise awareness of how many people per day, per week are on service who are high risk of readmission. The high-risk flag can then promote a workflow process that's enhanced above and beyond standard care. So that might mean that a pharmacist comes and conducts a medication review, or that all of those patients receive bedside delivery of medications prior to discharge, or that all of those patients receive a 48-hour follow-up point of contact, etc. You can use the alerts that are triggered to populate analyses and tracking on your operational dashboard, so that if you program a flag to identify patients with these high-risk features, you can use that as a count of all patients admitted with high-risk features. You can then measure how many came per day, per month. You can measure what did we want to do and what was actually done for each of those high-risk patients, et cetera. And then, of course, you can analyze the outcome, the readmission rate of all patients who triggered an alert. So we really recommend that you develop and use high-risk flags for not only individual patient care, but then to support the promotion of enhanced care, as well as the implementation and outcomes analytics on top of that. Here's two examples of a flag that really creates efficiency and improvements in standard hospital-based processes. So the first is a flag that populates a high-risk patient work list. And this example comes from a hospital that has a 10-person team dedicated to improving care for patients with behavioral health conditions who come to the hospital. And so the model rests on navigators in the emergency room and in the inpatient setting being able to identify patients with behavioral health conditions so that the initial engagement, the assessment, and the offer of post-hospital continuation of care and support can occur while the patient is on site, whether that's in the ED or in the inpatient setting. For the first 6 months of the program, this team struggled as the nurse navigator assigned to engage with the inpatients was spending 3 to 4 hours of her time every morning reviewing the H&P and the nursing assessments of each admission to med-surg every day. And she was combing through charts and records and trying to attend rounds and trying her hardest to identify which of today's new patients have a behavioral health condition that would qualify them for this enhanced service. That was taking a Herculean amount of effort. The hospital prioritized, based on how much time this was taking, the hospital prioritized the development of an automated flag to provide her with a 7 a.m. list every morning of patients who were admitted overnight in the past 24 hours who had a behavioral health comorbidity associated with a prior bill in the past 12 months. This returned 3 hours of clinical care to her day every day, 15 hours of clinical care back to her week. And you can imagine how much more clinically productive she is in actually engaging and serving the patients that she's supposed to be working with instead of working so hard to even just find who they are. The second example was a very clever initiative based out of a hospital in Texas who was focused on improving the transition of care for patients who were going to skilled nursing facilities. And they had identified in their data that patients discharged to skilled nursing facilities had very high readmission rates. So what they wanted to do was to address this high readmission rate by improving the quality of the medication list and as well as the quality of the medications that were recommended, the optimization of that list to the skilled nursing facility at the time of discharge. So they implemented a flag in their inpatient case management system. As soon as a patient was screened and accepted to a skilled nursing facility, a flag went to the pharmacy department and created a notification so that the pharmacist would come and do a final med review, med optimization, and then also allowed the case manager to know that that pharmacist was getting that flag and that there was an expectation that that review and assessment would be done within about an hour so that it wouldn't, quote, hold up the discharge. And so they used, just as I said on a prior slide, they used the flag to generate a list of all patients who met criteria for the service, which allowed the team to measure and improve the process, the implementation of this process of getting a high-quality medication review and optimization done for each SNF patient before they left the hospital. A very successful undertaking for them. So in conclusion, we encourage you to improve standard care, and the key way of doing that, we recommend is review the expectations that are being put forth in guidance and proposed rules from CMS, and to the extent that it applies, your own state Medicaid agencies and any other relevant regulatory or payer-based expectations that you have. To look at those as those expectations as elevating the standard of care for all patients, and then looking for opportunities to reliably improve your processes by incorporating these process improvements into standard workflow elements, electronic workflow, prompts, checkboxes, flags, etc. So the work of improving transitional care to reduce readmissions really is the work of delivery system transformation. And what we're doing is we're working to make standard day-to-day processes more effective, more efficient, higher quality, and patient-centered. Some of the tools that we describe in the later part of the chapter on this topic include using enabling tools and technologies such as flags, prompts, reminders, developing written standard operating procedures so that the process of care is known. Once you have a known process of care, you can update workflow, roles and responsibilities, communication and training materials, and you can develop processes and structure to measure implementation and provide performance feedback to the various interdisciplinary roles that are collectively responsible for assessing, treating, and transitioning patients from the hospital to the next setting of care. So in summary, would hope that you consider improving hospital-based transitional care processes for all patients, including but not limited to patients identified as, quote, high risk. We emphasize the guidance and proposals from CMS because they do represent Medicaid relevant and whole person enhancements to transitional care. Specifically, CMS reminds us that their guidance and requirements apply to Medicaid as well as Medicare, and they encourage us to identify and to assess and plan for behavioral health follow-up. They encourage us to specifically link to services and supports, not just refer to, and to ensure follow-up occurs for high risk. All of these elements are very germane to expanding your readmission reduction work to be specifically more effective for a Medicaid population. And then finally, reference the tools and content in this guide to help your teams apply this guidance in practice. So thank you for joining us for webinar 4 of this 6-part series, and thank you so much for your commitment to reducing readmissions. On behalf of my co-investigators, Dr. Angel Burgoyne and Jim Maxwell at John Snow, Inc., I thank you for attending this webinar and have a great rest of your day.